grade lymphedema into several classifications, and mostly with the breast cancer patients, we see a grade 1 or grade 2, latent or subclinical stage, a reversible lymphedema, and then a grade 3 irreversible lymphedema. And this is just a picture of the very beginning stages with the swollen extremities. And here is a later stage, which you may see. We don't see a whole lot of this in the United States, but you may see some people. So how do we diagnose this? We do it for medical history, clinical examination, temperature, pain. Ladies are unable to perform their daily activities with their arms. And here we are. How do we measure it? We measure it by several different ways. We can just take simple measurements. We can do water displacement, and we can do something called infrared barometry, which is a special machine that basically goes up and down the extremity. You can tell where the fluid is and the size of the different areas and compartments of your extremities, which is helpful for somebody that's treating lymphedema. Lymphoscintigraphy actually shows us the lymph nodes and the channels that are functional or non-functional. So this is a picture of a patient with breast cancer, and that lymph system's not working. Here's a patient that's had an implanted lymph node, and here it is functional. So what do we do to treat these people? Unfortunately, this disease has been around for thousands of years, and we haven't had a good result in treatment. However, we do have some drugs that can help the disease. We can do a bunch of compression, massage, or complete congestive therapy, and then finally surgical treatment. In the past, the procedures were pretty barbaric, where we had to remove much of the skin and the fat and even the muscles of the leg, leaving women just absolutely horrified, debilitating, and aesthetically unpleasant. So, two of the newer procedures are the lymph node anastomosis and chronic venous anastomosis. And both of them have a reasonable result in decreasing lymphedema. But today we're just going to specifically talk about the lymph node transfer. And we perform this in New York City. This is Dr. Corinne Becker, who's actually the pioneer of this procedure that I trained with in Paris. And these are her slides. And you can tell here's a lady with lymphedema. She's had a mastectomy. And this is her 1 year, 2 year post-operatively. And you can tell that her form and function has been restored. And this is her lymphoscintigraphy that shows no lymph nodes, and then after the transplantation, how it's functioning. So let's talk about breast reconstruction. Unfortunately, 1 in 7 women will have breast cancer throughout their lives. That's still a very high number. About 5 years ago, it was 1 in 8. So we're still moving forward, unfortunately, with that percentage of women that are having breast cancer. So when we reconstruct the women, we can opt for nothing, not a very good result. You can have autologous tissue, which simply means to use your own body, or you can have implants. So what do we use for our own natural body for breast cancer reconstruction? There's a couple different areas by which we do. One is the belly. Lots of women, when we exercise, we go on those diets, we never quite lose that belly fat, especially if we've had children. So this is a good result for a patient that wants a tummy tuck and nice breasts. And that's the tram versus the DIP. The difference is the tram takes the muscle and the DIP doesn't. And if you're into Pilates, tennis, golf, yoga, you probably would want to do the DIP because it allows you to be more functional than if you were not to have your abdominal muscle. The profunda artery perforator flap and the transverse upper gracilis flap are newer techniques for breast reconstruction, and these are for women that have undergone tummy tucks or liposuction, and for whatever reason their doctor didn't tell them that once your tummy is gone from liposuction or abdominoplasty, we can no longer use that for breast reconstruction. But this is another option. And our last option is something called the S or I gap, and that's where you use tissue from your buttocks. So a lot of us have the muffin top, I like to call it the muffin top, and we've been through exercise again, and we can't get rid of the muffin top. But in these procedures, we can incorporate that extra area of tissue to make a fuller, more natural looking breast. And once you go through your procedures, they're your breasts for life. You don't have to worry about them. Unlike implant therapy, at times they may rupture and they may cause problems in the future. So this is a pap flap. This is a lady with a BRCA gene who had a cancer in her breast. She underwent bilateral nipple-sparing mastectomies. And we took tissue from the back of her thigh and we made her breast. And this is her. Now who can tell me where the tissue was taken? Anyone? Volunteer? Where? Come here. Come up here. What's your name? Judith. Judith. Where? Take the pointer and point to me. Where do you think the tissue was taken?
Yeah.
No. What's your name?
Shelley.
Shelley. Why'd you point? Tell me where the tissue was taken.
Yeah. There you go. Not from there. Where you point? The lower.
Here. Here's your pointer right there. So you point. Oh, this one right here.
Okay. From there?
You're close.
I think so.
What do you think?
Right on the side.
Oh, this button right here. Okay. Well, ladies, those are all very good places that I would like to take tissue as a surgeon, but you're all wrong. Where did I take this lady's tissue? Right there. No, she said it right here. It's right there.
Only one place.
No, I'm sorry. You did say she's bilateral. I apologize. You are correct. What I wanted you to show me is both. And you're right. Okay? But if you look at her buttocks, it's reasonable to hide in a bathing suit someone who's had breast cancer. This is a very young lady. She modeled all over Europe in the 80s. Very much involved in fashion, a mother of twins, very active, and she said to me, I don't want to look non-proportional, and I want my scars set. So we did that. Let's move forward. This lady's a little different story. She's had a little bit more work. She's had some cancer here. Unfortunately, the doctor who took out the lumpectomy took out half of her breast. All right, now what? What do? Well, we got to fill it. She's had a tummy tuck. She's had liposuction everywhere. So with this woman, and I always get the heart cases, because if you're going to come to me, I'm the one that I come to for the heart cases. So we got to find out where we're going to do her tissue. So moving forward, and this is a little bit more noticeable. But you can tell right there, the unilateral. Okay? And her buttocks contour is really nice. These are my markings, and going back is what we do is we fat wrap. We take all that extra fat that you don't want, and we place it in the breast. So we can do this for natural breast augmentation, and we can do this for breast reconstruction for cancer. And once the fat takes, it's it's a breast size for the rest of your life, which are nice options, again, if you don't want to go the implant route, especially for augmentation. Yes, question? I promise you I can get fat almost off of anyone. It's the way our bodies were designed, evolutionary-wise. We have these special areas that no matter we diet and exercise, we still can't get rid of it, which is a drag. But us, using our instruments, we can get rid of it. And why throw it out? We can put it into places that look better with a little extra plumbing. Face, breasts, and other areas. So that's what we can do. Really? All right, so with this lady, we went ahead and put a flap there, and we also, she's not done clearly, and she'll look a lot better, and this is a fresh picture. Okay, and this is her donor site. This is another lady that we took from her thighs. Not bad, she's more interested in just fitting in a bra. This is a lady that had one breast done. Which breast? Which breast was done?
The right.
Right? 50%. Wrong.
I would say right from this view.
On the patient's right or my right?
The patient's left. Right.
No, the patient's left. Exactly. So look, there's her incision. Right there. Now, this is a good picture because I clearly put this in my slide. I've had her for a couple of years. The other one I had for 6 weeks. A little bit different. Okay, but that's a nice result. So let's talk about the different breast reconstructions real quickly. The DIEP, and we talked about this, is we just remove fat and skin from the belly and give you a tummy tuck. So all those tummy tuck patients that had that tissue removed, we could have used it for the breast if they got breast cancer, 1 in 7. Ouch. Okay, this is a fresh picture. This is a 25-year-old with breast cancer. Wow, right? They're getting younger, and we're getting the ability to pick it up at a younger age. That's unfortunate. But here is a bright, intelligent girl going for her PhD that opted for bilateral mastectomies because of her prognosis. Okay, because ideally we want you to live. We want you to look good, but we want you to live. And we actually took her belly. Now this lady's real thin, right? But she had little breasts. So we were able to take the breasts and make nice A-B cups. Here's another lady. Which breast was reconstructed, right or left? Her right or her left? Her right. Yeah, you guys are catching on. Awesome. I'll hire you guys for one of my patients. Okay. This is the breast that has the cancer. So we just poured it out, kind of like removed the inside, and we replaced it with her belly. She got a nice tummy tuck, and we gave her a little bit of a lift.
How does that scar heal, the tummy tuck?
These are fresh scars. Within a year, if any of you had a C-section with having any kind of children, it eventually would heal like a C-section scar, which will be barely noticeable. Or if you've had an abdominoplasty for cosmetic procedures, after about a year, they're really imperceptible. Again, these are all fresh, somewhat fresh pictures. Okay, so now we're going to talk about the lymph nodes, and these are the patients that have these swollen extremities, and what do? Well, we take a little bit of fat. My pointer's gone. A little bit of fat with a lymph node, 1 or 2, and we transplant it underneath the arm. And as a result, we can decrease the size of the arm. The picture on the left shows a wider arm, and the picture on the left shows a thinner arm after the procedure. Okay, this is a patient who had lymphedema. Her lymphedema, and do we have another pointer? Okay. Her arm is a little bit thick here. So this is where her lymphedema is, and it's really subtle. And I apologize you guys don't see it, but I'm going to tell you that this lady resolved 100%. 100% her arm went down after this procedure. She's had bilateral mastectomies with implants. Her implants became rock hard, painful, and temperature sensitive. She's from the south, so it's very uncomfortable for her. So she came to me, and she wanted her implants out no matter what. And she wanted her arm to be treated. So we took the fat and the skin, and this is where we took a little lymph node pocket. Skin, fat, and 1 or 2 lymph nodes. And we went into this breast under that arm. This is her a little bit after. I'm sorry, it's a little bit poor picture because you see these little wings. She's got nice symmetry, natural looking breast, and this arm has gone down 100%. Okay, in New York City, in our group, my group, I've done 40 of these surgeries since 2007. Okay, and they're from all ages, all backgrounds of ladies that had all breast cancer, all lymph node dissections, and some with or without radiation. So when we perform the breast reconstruction and the lymph node transfer with the patients, we generally follow these patients for many months after the surgery because it's more of a team effort. They undergo a tremendous amount of therapy. They go daily for 3 months and then weekly for 3 to 6 months afterwards. In up to 2 years, their lymphedema should resolve.
Was the surgery done right after the mastectomy?
Right at the same time. It can be, or it can be done what we call delayed at a different setting.
Is one more preferable?
Well, I think whenever we remove women's breasts, I think personally, I think the woman should wake up looking like a whole and not looking like she's been separated. So for a woman to wake up without any breasts, I think is disturbing. So the patients that I see, I very much advocate for immediate reconstruction. And whatever they want, that's fine with them. But I believe that they actually should have reconstruction at the time. Mentally, once the mental aspect of their healing process is up to speed, physical follows so quickly, and I think that's a really important thing to notice as a surgeon. Not just the surgery, it's the whole person that we need to look at. Okay, so what happens with these ladies? Well, the arms get measured, the arm garments. I don't know if you've seen these ladies. They have the stockings, you see them on the airplane, they got the funky little clothes on, they're hot in the summer, they're miserable, they never have jewelry on, it's amazing. They never wear short sleeve or tank tops because they're constantly looking around like who's looking at them because they already look abnormal compared to the rest of the population. The result of the surgery, this is what they say to me: back to normal, lighter, jewelry, wedding rings, the most important, wedding rings, watches, really simple things that I think we take for granted that these ladies don't. Okay. So what are my personal results in my hands? Well, 7 patients had complete resolution, 100%, which I think is a pretty good. That's pretty good in the United States. Right now, there's only maybe about 15 surgeons that perform this. 24 patients greater than 50%, 8 patients less than 50%, and 1 patient with no improvement. Now, what's interesting about this is that even the patients, 8 with less than 50%, every single one of them say to me that they would go through the surgery again because they got some kind of result. Not as much as we hope, but they got something. And that to them changed the world. Okay, I'm sorry about the pictures. I hope you guys don't necessarily get a little queasy here, but typical mastectomy patient, that's how they look, that's how they wake up, okay? I don't really like that look, but this patient decided to wait. And we go ahead and we use her nice belly. There's our little lip note flap. And we're gonna make 2 breasts. One not a scratch, and one we're gonna just core out the inside of this one and just kind of fill it in. There she is. 6 months. I don't see, you know what, I erased her pre-op picture. But this arm, twice the size. You can believe me or not, I don't have the picture. I probably would want to see the picture, but it did. It was twice as large. And there she is, totally reconstructed, with the sleeve and without. Here's another lady, again a little slow. Right in here, it's bigger. A little bit right in there compared to that. This is where you really notice the difference. 50%. And there she is reconstructed. Now, as a plastic surgeon, we are very much prone to making the body look proportional and as beautiful. That's including the face. Now, I'm a plastic surgeon that does everything. I'm board certified in head and neck and plastic surgery. So I can do your facelifts and your brow lifts and your noses, the breasts, the tummy, the liking, all of it, plus the breast reconstruction. Okay, because it's a comprehensive package with women. These women that do all this with the breast cancer have a renewed sense of who they are, and then they go forward with the other procedures, and they move forward with their life and they're happy. So that's my presentation. I know it's not cosmetic, and I know most of you guys and most of your women here are here for cosmetic, and I'm happy to answer any cosmetic questions. You know, I do a ton of it, and I also do breast reconstruction, and I think also just to get the word out that women have options, and we are moving into Breast Cancer Month, and I wanted to sit down and just kind of mention that. Does anyone have any questions or any comments or anything for me? No? 100% by insurance. All these women have everything paid by insurance. Absolutely. Women should not have to pay for this out of their own
You
pocket.
don't do any implant at all cosmetically? You don't do implants cosmetically? You're not in favor of implants? Is that what
You mean for breast augmentation?
Yes.
I will do what the woman wants for augmentation. I will present all the options, and then ultimately she makes the decision. So implants are fine. Implants are, it's like owning a foreign car. You have to pay attention to them. You have to be aware of the implants. They don't last forever. Quite often they have to be exchanged. If you have silicone, recommendations every 10 years now. MRIs to make sure they don't leak. And if there's problems, sometimes the body just doesn't like them. And they form scar tissue in the implants, and we have to remove it.
But just for cosmetic aesthetics, you don't do the fat.
We do. If you want to do just the natural augmentation, which is your own body fat, I do that. Once the fat takes, it lasts for a life, but it may take 1 or 2 or even 3 sessions. A fat is called fat burning.
Oh, so even if there's no cancer involved, it's not reconstruction.
No, that's just
You
for-
will still use the fat.
Yeah, absolutely. And I use the fat for buttock grafting. A lot of women want, when the Kardashians and J-Lo, very popular following with many women in the United States. So they come to me and they say, I would like a little bit of a fuller booty. Can you help me, Dr. LoTempio? And I said, sure, I can help you. So we take some of their fat in their little troublesome areas and we put it in the booty. And we can sculpt a beautiful booty. And I've had really good results from those women, and they've been really happy. Ladies, thank you so much for sitting through my presentation. Have a wonderful week.